as you know, with these conferences that Mark runs, he likes to make sure there's ample time for mingling. And so we'll have lunchtime and I think another break in the afternoon. My name's Anita. I'm a portfolio GP. I work 3 days a week as a medical monitor for Lindus Health, and they're a health tech startup in clinical trials. I also work as a digital transformation clinical lead. That's a bit of a mouthful, but that's at South East London for the ICB. And the other days of the week that I focus on well-being because, like Nadia, I have been burnt out before and trying to kind of recalibrate and find balance because there is such thing as techno stress and just too much digital, and sometimes we do need to kind of disengage a little bit. So it brings me great pleasure and excitement to chair this next panel. They're a formidable bunch. I've met a few of them. It's going to be really funny. 10 minutes presentations each with 20 minutes Q&A at the end. Great. So we first have up Mike Kriger. He's a professional troublemaker. He's an anaesthetic registrar all the way from West Scotland. Has anyone travelled further than West Scotland? West of Scotland? No? Oh, wait, Dion? Netherlands, okay, that's fair. That's commitment right there. And the gentleman behind you? Where? Arctic Circle. We have someone from the Arctic Circle. Well done. Mark, did you get that on your map? Make sure you map that out. With Mike, he's great human. He is a clinician who codes. He runs the NHS Hack Days. I think he ran a session at Chal West like 2 weekends ago. I signed up, but I couldn't make it because I decided to burrito in bed. I was just tired and I just needed a bit of a break. But he's going to come up and deliver a great presentation. I hope you guys enjoy. Give it up for Mike.
Right. Digital transformation and the problem with digital paper. I think it's digital paper. I think actually it's a term Marcus coined years ago, but I may be making that up. So 10 minutes, very quick. So I'm going to be going at breakneck speed. Some things will lack detail and be glossed over. It's not that important. You should still be able to follow the thread and kind of message of what I'm trying to get across in this talk. And there will be a written version of this talk with details at some point. Disclaimer, health warning. Yeah, you might be able to figure out which department this is, where it is. I'm not trying to blame individuals or organizations. It just happens it's a very nice example of this kind of phenomenon that is endemic in digital health. Likewise, again, I'm not pointing fingers at particular EHR vendors. This just happens again to be the one that was in this example. So let's start with a story or a premise, really. So we are in the gold rush era of digital transformation. Digital transformation, you might have a definition in your head, you might not. There's lots of definitions. This is my definition. Digital transformation, the focus is more on the transformation bit. So shifting the current ways of working to embrace technology to save time, money, improve efficiency, and improve patient experience. Definitely gold rush. 3.4 billion announced at the last budget. We'll see what it changes to in the new budget. But anyway, targets from the centre. In terms of, say, in England, in terms of setting. Digitizing things. So definitely kind of gold rush era. All with the idea that we're going to save time, save money, improve efficiency, increase safety. You kind of get the story. Back to the story. My story focuses on a very small little bit of digital transformation. You might have recognized the picture, but it relates to obstetrics and anesthetic involvement in obstetrics. So the tiny little bit in the corner here, so the epidural there. So if this was a different conference and a different talk, this would be my opening slide. Transforming anesthetic maternity services using digital transformation, decrease waiting time for epidurals, increasing safety, saving money. You can kind of probably guess where we're heading with this at this point. little bit of context, some clinicians, non-clinicians, in the UK, if you're giving birth in a unit that's attached to a hospital, you have some choices for analgesia. One of those is an epidural that's managed by anaesthetic team, and there are standards in terms of follow-up and looking after these patients. So 24 hours after delivery, they're followed up by an anaesthetic team. There's some also kind of national standards that are audited against, and data is collected for those standards. So every unit has a process of some variety to collect that data and ensure these follow-ups happen safely. In our particular case study, this is how things worked. So a simple 2-page form printed back to front. You might be able to see there. It takes about 10, 20 seconds to fill in. You tick a couple of boxes, extra procedures during the admission. You kind of tick some more boxes. There's some bits in terms of follow-up you fill in, and then it gets filed in the patient notes. And for workflow management, there's this amazing bit of technology that was used. Very simple tray. Patients still on the unit, patients to follow up, patients that still need follow-up, and bits that need filing. Really simple, intuitive. The training for that, for a new anaesthetist working on the unit, I've just done it. It's simple. Now, digital transformation happened, and we got this. Now, this is sped up 4 times because I only have 10 minutes and I need to kind of rush through. So you may have just missed it flashing by there, but there are a couple of things that you may have noticed was, yes, that was the order.com screen where you order blood tests that brought that form up. Yes, the first couple of fields are repeating information that is already on the screen in terms of gestational age and other information in the system like the BMI and other things like that. There are a whole lot of other kind of clinical safety issues and things with this. We don't have time to go into that. It's not important. I also don't have the workflow bit video because that's much longer and much more complicated, but it's not important. In real time, that video of somebody who knows what they're doing and is fully trained and versed in that and is already logged into the EPR and found a computer, it's 1 minute 40 seconds. And the computer's working. 1 minute 40 seconds, it's not a huge amount of time, aside the other bits. But let's just put that in context. So in the health board that this example comes from, stats show that for last year, there were just shy of 10,000 births. Nationally, there's about a 60% epidural rate, but there are probably more patients involved in terms of the anaesthetic team with C-sections and other things, so this is probably conservative. So there's probably about 5,000 odd births times 1 minute 40 seconds. That's 6.5 days that this digital transformation has taken away from staff. If you put my measly hourly rate on there, which I had to work out, that's just north of $5,000 of doctor time that you've just wasted. And again, variable, but you can say it takes about 30 minutes to put in an epidural. That's 312 epidurals you've lost. So great digital transformation, aside the safety issues and other things and what have you. But that was the case study. We've glossed over it. How can we do better? This is the most important part of the talk. So there are 4 things. 1, we're doing right now, education. So understanding that most digital transformation, I'm sure most of you have worked somewhere where something has changed and been digitally transformed and you've ended up with something like this. So knowing that this happens and it's bad, and knowing about the things that we need to do to fix it. So procurement. I think Nadia's kind of talked about this before, earlier today. There are kind of important things here. So very quickly, for this particular EPR, it was procured off a framework that involved 5 health boards agreeing a spec. You can imagine those clinicians in the room getting multiple sites, multiple clinicians, everybody agreeing that. That probably did not happen quickly. So in April 2008, they, after spending who knows how long, probably more than a year agreeing a spec, put in a call for bids. In November, the framework was awarded. So that's a year since the framework was agreed. And then a 10-year contract was awarded with a 2-year implementation period. So 4 years from the point of inception of the needs of an organization, you've deployed your product. So do you think that really meets your organization's needs now? Probably not. And then guess what happens? You're kind of in your EPR optimization phase, still rolling it out to extra units or departments or whatever. So you're still kind of building things out. So you kind of invested time and energy, and you're all sunk cost into this EPR. So all of these products and projects, the contract gets extended. So this one it was extended 9 years to 2029, and I guarantee you it's going to have another extension for the similar reasons. So the cycle time on these things, that's 20, 30 years from inception of spec and needs that we saw we don't meet on day one. What are we going to meet in 20, 30 years' time? So that's a huge issue with procurement. And we'll talk about the why and wherefore. The other issue of procurement is what you're actually buying. So aside from the spec and scope creep and stuff, this was the puff piece that the particular vendor put out. And what's that? Entered once? Didn't we just see double entry? And easy to use? So, no, I'm genuinely not dunking on the particular vendor and their sales teams. They're all as bad as each other. You just have to look at the HSJ headline from a couple of months ago talking about, I believe, Epic in Exeter. So you've got to think a bit more about what you're buying and the fact that you're stuck with it for 30 years, and maybe we shouldn't be buying something like that. But the reason you get stuck with it for 30 years is because you're stuck with the data in a massive walled garden. So those of you who've been floating around in this sector for long enough, I need to speed up, probably know who Rachel Dunscombe is, and she says it best, data is for life, not just for one system. And if we consider that as a key principle, we will design and procure systems differently. So if you have portability around data, not only can you roll things out slower, change things, have continuous cycles of improvement and kind of agile development of different parts of your EPR, and not get stuck in these 30-year big bang procurement cycles, that kind of a vicious cycle. So the data is the key thing. The other thing, opportunity cost, is something that boards struggle to understand, and they've got those central government targets. You need to do this now, but you just saw my very cheap napkin math numbers there, that the rushing into this transformation has actual real negative costs, aside from, again, the clinical safety issues that I brushed over. There are whole bigger costs, actually. So doing something quickly and doing it wrong, or doing something at all, actually is sometimes worse than doing nothing. And this is not unique in the public sector. So this was a quote from the Public Accounts Committee looking at the public sector and digital transformation, rushing into doing digital transformation when actually, if you thought about it, you could have thought, well, ideally we'd move this kind of double entry with the epidural thing, because most of that I'm documenting anyway on a bit of paper. But if you use the clinical data, you'd enter it once, it would solve the problem. You're not kind of adding an extra force. It's the same thing. You need to actually transform the whole process and think about it. Or again, get it right first time. This is more about a clinical thing, but I couldn't resist it. So really, the message, education, understand we do digital transformation wrong most of the time. Procurement, we need to think about this, particularly in the context of data, and realize that we are buying something probably for the next 30 years, and you need to do it better so that you can change things within that 30-year period and do it right. And opportunity cost, don't rush into and do something that is actually going to cost you more. And that is me 2 minutes over, so I will stop talking.
Thank you very much, Mike. See, troublemaker. Already running 2 minutes behind. It's okay. It's okay. I've got this. So very, very thought-provoking presentation, very clearly delivered as well. We'll have to save questions to the end. Next up, we have Michal Pruski. Let me do the introduction. Take a seat. Or you can stand with me, it's fine. He is fashionista. I love his jacket. I am sure everyone looked at that and be like, wow. But you guys at home, you'll get a view of it very shortly. So this guy's a bit of a celebrity, and I'll tell you why. He is the only higher, scientist, specialist, trainee in the whole of UK. That's quite a big deal considering we're in health informatics. That's quite a big deal considering we're, you know, managing lots of data and we're all kind of working in health informatics anyway. And he's passionate about kind of promoting the healthcare science workforce, and he'll tell you a bit more about that now.
Thank you. So, yeah, if you just put like wherever you've hidden the presentation. Oh, here we go. Thank you. Hello. So, thank you for the introduction, and this will be my massive moan for the next 10 minutes. So, a bit about healthcare science, in case you wonder what the heck a clinical scientist is. So, healthcare science is one of the professional job groupings that we have in the UK healthcare system. We're lumped together with perfusionists, biomedical scientists, and there's a lot of overlap between some of those disciplines. I always find it interesting that clinical photography is a scientific discipline, but yeah. And there's overlap between specialists. So we're not technically AHPs, but yeah, we contribute to like 80% of diagnostic decisions and stuff like that. And we have this, so I think for you to appreciate the things I'll be talking about a bit later on, I'll tell you a bit about how we're trained, usually. There is an undergraduate degree that you can do as part of your training, but I think a lot of people skip it. And they move to the scientist training program, which is like a master's level equivalent, and it's generally done in a specialism. So there are 3 informatics specialisms at the moment in the UK. You have clinical/health informatics, scientific computing, and genomics. And then you get your HCPC registration, and then you can go into a higher specialist scientist training program that's kind of meant to be mimicking this higher specialist training that the doctors get as well. And then you get to go on a special register. And you get 3 years of master's training, so your employer generally gets some money for you to do it. So all the, I want to say health boards, but whatever you have in England and stuff like that, you all pay into a training fund, and you can get some trainees as part of that. So funding is for 3 years at a band 6, and then for HSST you get 5 years on a 8A equivalent money for that. Unless you're an in-service trainee, there's no guarantee for a job for you as a trainee, but maybe if you're an employer, that's a bit less risk for you. And training is usually in one specialism. I'm a bit different. I've moved a bit between specialisms. And yeah, it's meant to emulate medical training. And then a qualified clinical scientist is on a band 7, and if you're a clinical science consultant, you're meant to be in an 8C or above. And it's not the same as the NHS graduate management training program, in case anyone was wondering. So we have the 3 informatics specialisms in healthcare science. Genomics does basically what the name says it does. They mainly work with life science, with the life science specialisms. And then clinical scientific computing tends to be more the nitty-gritty programming and stuff like that, work a lot with medical devices. Whereas clinical/health informatics, and I say clinical/ because they renamed everything for some reason at some point, I think in 2017 or 2018. It's meant to be more either implementation or data analysis. Apparently, historically, it came all from the labs, and then it kind of got messed up. But I think the key point here is that, you know, you often hear things about like digital doctor or digital nurse, and they're meant to be doing digital nurses are meant to be doing digital for nursing, and digital doctors are meant to be doing digital for doctoring. Clinical scientists working in these specialisms are not meant to be doing digital for other clinical scientists. Like, the point of having a health informatics trainee is that they can then pop into other specialisms and do the informatic bits for you, because they should have enough clinical appreciation to help to understand of what you're telling them, and then to put it into whatever digital context. And I think that's the only accredited specialist training pathway in health informatics that's in the UK. I don't think there's any other officially recognized certification in health informatics for the other professions. But we also suffer from the fact that there's no single professional body for us, so we have pretty much no professional representation. Even for genomics, if you're doing pathogen genomics, you're in one group, whereas if you do human genomics, you're in another group. So it's hard for us to rally together. But we did get a mention in the Topol review, which is kind of my main point of contention, that there should be attractive career pathways, and they specifically in recommendation G6 and E9 mentioned the higher specialist training. And it's been a couple of years since the Topol review. So I'm going to show you in a moment some data, but the situation was so bad, especially with regards to staff retention, for people who completed the STP, the scientist training program, that NHS Education, or whatever it was called at that time, decided to do a review of what was happening with the workforce that taxpayers spend their money on training. So in 2020, out of seven qualified healthcare scientists, I think 2 remained in post. So that's a dropout rate of quite a lot. And I think the key is always on the anecdotal feedback, because here it's suggested that clinical bioinformaticians in NHS trusts felt they were not fully utilized. Further personal anecdotal feedback suggests that some people decided to treat them as IT support, or whatever else of that sort of ilk, which wasn't helping. And it's probably not a problem just for healthcare scientists. It probably affects other professions as well, that you're there trying to train in something and somebody else is hijacking your training and getting a preference to learn the skills and stuff like that. So it's maybe not very unique. So just to point out, when I say I'm the only one, well, there were 3 posts taken and 2 left, so that leaves me as the only one, and that's data from 2018 to 2023. But as you can see, I mean, there's obviously a problem in the sense that the years don't overlap. As in, for 2018, we know who's left, but we don't have any more data, of who came from then, so they don't align perfectly. But I think it's still telling that, for like scientific computing, you end up like with 12 people being employed at the end, and clinical informatics is just abysmal compared to how many, places were taken. This doesn't go forward. Here we go. And that's data specifically for Wales. And you have for some reason, NHS England would give me less than 5, would specify it, but NHS Wales said no. But I can tell you that the 3 less than 5s in this column amounts to 3 people. So that's not particularly good, looking at the Topol review, and you can see everywhere here is less than 5 as well for the STP. And Academy of Healthcare Science holds the specialist register, And last time I've checked it, there was nobody in any of the informatics specialisms across the whole of the UK. I know one person who has just started recently a joint post between a pathological discipline and informatics in the northwest of England. So perhaps there is some hope. But I do wonder, why does nobody want to take up the offer? I mean, there's a shortage of registered healthcare staff. I mean, nobody's complaining that they have too many staff to work in their department, and everybody's just fiddling with their funds. Well, everybody is complaining that there's not enough people to do digital transformation. We're busy redirecting staff, and I can appreciate that there's a tension between the fact that everyone has their personal interests and, you know, wants to go and do something a bit more than just their bit. But you know, you get essentially a free trainee for 3 years for the STP, and you know, something similar for the HSST. I don't think any of the CCIOs are particularly interested. You know, I don't even know if they're aware that this training pathway exists, and you would hope that they would have. And it feels very weird because we have all this stuff about informatics being a space for the professions to go and to contribute, but that almost seems to be excluding the one profession that's designed, you know, from start to finish to go in there. But maybe we just don't sound as attractive as a digital doctor or a digital nurse. And yeah, just in case anyone thinks that this is like a new thing, modernizing scientific careers happened in 2010, and that just lumped all the healthcare scientist groups into the clinical scientist bracket. So they did exist before that. And then there was a revamp in 2018. So we did have a good couple of years of being around. And that's the end of my talk. Thank you.
Thank you so much. Thank you so much, Michal. So let's just kind of ask that question, Michal. Before this presentation, thanks, Mike. Troublemaker, Mike. Before this presentation, how many of you knew about this program? Put your hands up. What do you think about that? Is that good or bad for you? No, Michal.
It's probably better than I expected.
Better than expected, he said. Better than expected. We'll continue working on that. Thank you very much. So the next presentation, I think, is a double act. We have Marcus Ball, who's a portfolio GP, a clinician who codes, and the king of open source. We also have Tom Stocker, who's someone who works at Clatterbridge Cancer Centre. He delivers digital strategy and also the EPR programs over there, and does a lot of work, including working on the clinical digital manifesto. So give it up for them both.
Are you all ready to go? Yeah.
There you are.
Feeling back already. It's like being in my band. Well, Mixer, he's got that. The man on the riding the faders, giving me 1,000-yard stare of like, it's not my problem. We don't have kings in open source anyway. I prefer we have benevolent dictator for life, which is what I am of some things. This is a double act, but actually, Tom I'm more of the Bez of this double act. So
Yeah,
I'm
cool.
just
Shall we?
on this side.
Shall we? This is
Tom,
this is
you go
kind of a
ahead.
pitch. So I think if we go to the next slide, Marcus and I were having a chat and we were reflecting. So I think we both got into digital and quite an excited, like wet behind the ears puppy mentality. I saw the power of data in my first job, where we had everything in the health and social care system together and integrated. This is pre-Caldecott. I could go and pick a list of the most expensive patients. We're talking north of £250,000 a year. I could go to their GPs and say, can I have a chat with with Marge or Bob or whatever and understand what was going on, and then design services with clinicians to meet those needs. Try and do that today. Really, really hard. Then seeing the power of digital transformation and seeing some of the benefits that we could get from that was absolutely amazing. And it felt like this moment in football where at some point we were going to win something and bring it back. But we never did we? And I feel like the digital journey has almost copied that. Yes, we've got a few trusts with very, very good comms departments saying how wonderful their EPR is, etc. But if you look at the day-to-day experience of a clinician, we've got the kind of dynamics that Mike referred to earlier. Add up those 1.4 minutes across the whole NHS, and we have bogged ourselves down in something we're calling digital drag. And I think what we are trying to do here, be very open for your feedback, is how might we change that drag? Where does that drag come from? The people doing that Scottish procurement for track care, they didn't intend to slow Mike down, right? That wasn't the goal. Track care built something. They were trying to be useful. That wasn't their goal either. That they had other goals. But when you add up all these actors, we've got a coordination problem whereby we're not getting the feedback from the front line. We're not eliciting the feedback. We're not even got organizations that are capable of dealing with that feedback. We've got some real challenges that are distributed across patients, clinicians, suppliers, government, and trusts. And we think that actually we've got loads of skills networks, we've got loads of organizations, but there needs to be a space where we can have honest conversations about how we pull those different threads together and figure out our way. It's happened in central government. It's happening in local government with Kit Collingwood and OneGov Local. It's not yet happening in the NHS, outside of this room, but it's happening here. Can we go to the next slide? Can I click something or? That's not that, so. Well, from memory, what's next? The problem statement and the vision statement. I think we've talked a little bit about that.
Yeah. I think everybody in the room sort of will recognise, certainly if you're in a clinical role, you'll recognise the disconnect between the sort of shiny, happy world of how the tech is given to us and how we're told it's supposed to be working, and then the reality of working on a ward or working as GP and that sort of thing. And
luckily,
the distance between those has got wider as well, I think, over the past, say, 10, 15 years. Back in general practice, we used to have systems that were actually really quite good. And now you've got sort of 50% of GPs on a system that might crash first thing in the morning and won't come back up till lunchtime.
So, I've got a Wi-Fi blackout as well. I did have everything written down on a website that we could refer back to. But we've got 5 principles that we want to start this community around. Yeah, right, okay. So problem statement and vision statement, we've talked loosely about that, but at the end of the day, we want to take this clinical drag away, and we see that as a team sport between digital folk, clinical folk, management folk, and national folk and suppliers. But we need to drive that team sport in the NHS, and that's where we're hoping to go with this community. Can we go to the next one? So here are the principles. So these principles were developed with engagement of 60 plus national leaders, local people, clinicians, digital folk in our network, including people like Andrew Griffiths in the audience. And we took those 6 initial principles, and then we did an in-person policy hack at Rewired in March. A couple of people were there for, and we refined it. This last one said we're going to move away from big IT, because that was a core driving organising principle from OneGov across civil service. They used to be hooked on these big contracts with IBM or what have you, and they had to break that up, modularize it, and move it away into a completely different way of working. That worked over 10 years. That was 2005 to 2015. We're still hooked on the big IT, but at least there are other ways of doing it that departments have on offer and are familiar. That didn't go down very well with some of the NHS stakeholders that were in the room. What will my EPR supplier think if I'm part of this community and I'm calling out big IT? So we have changed it, because what came through really strongly from that engagement was actually, as a trust, I don't feel like I've got the support to do my job. I don't feel like my team between us is working together and has got all the right subject matter expertise to actually deliver what we need to deliver. So before we go and rip up the way that we engage with suppliers, which is a big, lumpy transition, there's something much more pressing to do around just supporting digital teams to have the confidence to listen to what their clinicians are going through and to bring together the technical skills, even if that's not in their trust, to template solutions. And actually, we think we can probably start to develop assets and be open in how we work so that we're not reinventing 273 times some of the projects that we do across our various organizations. Go to the next one. So this is a bit of audience participation. Next one again. We did a survey of clinicians in the run-up to the launch and the policy hack. And this is just the clinical responses. There are digital responses too, but this is just the clinical responses. So this was a question that we asked people. What do you think people said? What would you say to this question? I am quite breathy today. Yeah, thanks, Grant. Brilliant. When do you face frustration, delay, or difficulty with your digital tools and systems? Anyone prepared to share?
Every day.
Every hour, every day.
That's basically the feedback we got. Yeah, it's just it's all every hour.
Marcus, don't spoil the surprise. Yes. Yeah. Yeah.
Sorry, could we get the roaming mic for the people online to hear what's being said as well, please?
Yeah.
Sorry to be so demanding.
Thanks, Mark. Sorry, Anita.
I was going to say I've developed a digital patience now, so I've got to be patient with my patients, but I've also got to be really, really patient with the digital one. I always get stressed each day.
Otherwise, your emotions are off balance and poor next patient, right? Yeah, brilliant. Okay, so if we go to the next slide, here are some of the answers. Magic. All the time with every patient, every day, daily. That was the main response. Like, it's all really hard. That's the main feedback we got. Like, there's lots of other stories that you might get here. Like, this isn't actually software. A lot of this feedback, it's about connectivity. It's about having the right device, like having the right IT service desk response. We're in the second week without a single working printer throughout the adult inpatient psychiatry ward. We're dependent on paper, and despite persistent calls, this is still unresolved. We couldn't do bloods, forms, or anything. We had to laugh. So you're taking down a whole service or system. This wasn't us scraping the hidden corners of the NHS. This was a quick Google Forms and a tiny bit of advertisement, and we've already got horror stories around basically the EPR and all the stuff that's needed behind the EPR to make it work. It's not okay. It's not okay from a national perspective. It's not okay from a clinical perspective. It's not okay from a patient perspective or from a digital perspective or from a supplier perspective. But it's not going to change until we start making those links across all those different groups and figuring out where do we go from here. What do we tackle first? Otherwise, we'll just keep talking about the problems for another 10 years. And if that happens, I don't know what I would do myself. Next slide, please. Ask the audience again, what's helpful? What do you want to see more of?
I think we should have a framework where we train our CIOs and CCIOs. 'Cause at the moment, we have a heterogeneous group of people doing different things.
There's a couple of people in the audience that might be able to take that one up.
So what's helpful about digital tools compared to what we had before is having all the data in one place, being able to search to some extent, being able to communicate from one platform. Those
Brilliant.
things are, yeah.
Thanks.
Accessible IT help desk, remote and accessible.
Yeah.
The legibility, like paper requests.
Oh,
versus,
yeah.
You
What's
know,
this
like
prescription again?
you
Is
know,
that 10 or 100?
and the audit trail associated, with
Yeah.
it. Like, I think it takes long sometimes, whatever, the system is slow and stuff like that, but it's probably still faster than like going to like a billion of nodes, quite often.
Yeah.
X-rays, you can zoom.
Yeah.
Sorry, I'm going to go a little bit orthogonal. From a patient point of view, what this chap, sorry, I don't know your name, just said, I'd like all my data in one place, and I'd like to be able to communicate. Thank you.
It's pretty simple when you put it like that, isn't it? Yeah, brilliant. Okay, let's load up the replies. Same thing, really. Like not having to punch in the same data in 5 different places, being able to log into all your apps in one way. And the crazy thing for me, working across multiple trusts and being in this game for a while, is that the future is here, but not
Evenly distributed.
evenly distributed. So each of these things that people said they liked or they want more of, it exists somewhere, but not everywhere. So each trust has solved problems in a piecemeal way. And if we put all of those solutions together, we're probably getting quite close to what people are asking for. Okay, we need to rattle through some more slides, Mark.
It's an interesting comment about copy and paste, which is worth like just a 30-second detour, which is just that we look at copy and paste as though it's a failure, but it's often the workaround that provides a solution when the IT is itself a failure. Now, we could... copy and paste is something you could almost regard as like soft interoperability. It is interoperability, it's just not the one that you thought you wanted, but it does work. And there isn't a strong reason to throw it out as a completely unacceptable solution when it does work. It's the same mentality that throws out all the paper when we go digital, even when some of the paper workflows work kind of better, because paper has features that digital does not yet have.
So, yes, where research has been undertaken into the operational impact of an EPR deployment versus paper, the result has been so shocking that it's not been published. And that has been repeated across multiple countries. I've been involved in one of them. So I'm not allowed to tell you that there's the 20 to 45% drop in productivity when you digitize. And that research may or may not exist. Okay, next one. Yeah, but big question we get back is, okay, yeah, good, yeah, nice, Marcus, yeah, Tom, okay, but will it work? And that's a really important question because we've only got so many hours in the day. There's patient demands, there's digital demands, etc. Next slide, please. And I think the only person that can answer that question is yourselves as individuals. Like, is this something you want to put a bit of time in, see where it goes? It's quite early days. Our initial thoughts are that what the coup that happened with central government services, yeah, they had an easier job. It's basically websites. Apply for a passport, apply for a driving license, done. That's kind of what they had to do. So the tech code of practice, the service standard, ways of working with Discovery Alpha Beta Live were developed by an open community like the one that we're trying to create. And that's one of the hidden stories underneath the politics of how central government got much better at doing websites. So we think there's precedence. We think it's harder, but we think staying open, having an open agenda, being kind of NHS exclusive a bit so that we don't have our thoughts and conversations diluted too much, and just kind of being a bit responsive to where the opportunities are for us to progress as a community and taking it bit by bit over the long term, we've got a chance. It's happened before. Maybe there's a membership offer, and this is where I was trying to pin down Matt to see, as a CNIO here in this hospital, what would the barriers be to taking on some kind of membership where we try and work with both the clinicians and the digital team to increase the bandwidth between those two stakeholder groups and really get the digital agenda being driven by those clinical frontline problems. And then finally, like, a lot of the people that have shown early interest do want to influence. We've got things on the shelf, on our Trello agenda point, such as, why don't we have a digital standard contract for the NHS that gives us more legal leverage over the suppliers? Why don't we have some kind of frontline user experience feedback going into big projects and programs nationally, such as the FDP? And if they'd had that at the beginning, would it look different? And then finally, assets. The web and digital world in industry is built on repeatable assets, open or closed, paid for or free. There are repeatable assets where someone solves a problem, they create something that's very robust and does a small thing, and you use that robust thing in your app. So Elasticsearch is one. We're not saying we want to build the code, but we want to learn from that way of working that's very efficient to think about, what are those assets? Do we need to write the digital contract? Do we need to create the user research template for someone fresh out of university in a first role to go and start speaking to clinicians in a sensible way? We don't know what those assets will be, but we want those assets to underpin so that we've got evidence, we've got openness, and then we've got some means of affecting change long term. So thank you so much for listening. It's a bit of a sales pitch, which is a bit awkward. And next slide, please. Really interested, even if you don't want to be part of this, what are your priorities for advocacy? What are your feelings of like, oh, this won't work because, where's the hope?
And it's all deliberately very high level. You know, it's about where do we want to end up. We haven't really focused on the how, but we would like to hear from what you think about the how. How would we get from here to there? We've got precedent in the world of the internet, we've got precedent in the sort of governmental digital transformation, but we would have to do it differently because we're not the same as them. So it's like, what is the how for us? So join us.
Thanks very much.
Thank you very much, Marcus. Thank you very much. I don't think that was awkward at all. I think a lot of that presentation would resonate with us to some degree. And I definitely agree with your catchphrase. It's the future is here, but it's not distributed equally.
It's Carl Sagan's actually.
Yeah, I like that. It's absolutely true though, because some of the pain points that were up and there, I feel it, but in different areas of Southeast London. And I'm like, why? Why is it like this? We should be sharing good practice and we should be implementing it all. Right, should we bring up the other speakers and have our Q&A? Yeah, excellent. So we're going to engage with the folks back at home, or wherever home is, but online, that's what I was really trying to say. So Mark, are you able to let us know some of the questions they've asked? Hi, folks at home.
Of course. We've had someone quoting Mike, data is for life, such a great quote. So thank you for that one. And David asked, why don't we build our own API modules and license them to the EHR vendors?
Because they won't pay for them. as we have found in the RCPCH, trying to, we've built digital growth charts, which is an API. We've attempted to take something that was previously difficult, wrap it in a completely self-contained, easy layer, but most of the big EHRs just say, we don't need this, we'll just roll our own and we'll get the maths wrong and you won't be able to complain about it, but they don't want to pay for it. The small vendors are all over it. They think it's brilliant. So that's why that doesn't necessarily work as a kind of ransom strip, as in if we build the APIs and make them use them. We have to get them to the point where they want to use them because it's a business advantage to them. And at that point, you've got them.
So I haven't got any more questions, but lots of comments, really great comments. So Dorothy says, from what Michael says, whether we do it slowly or quickly, we're getting it wrong, exclamation mark. And the other one is, I think the copy-paste was, for me, I stand by it.
who do we actually have a name for that?
No, it's an abbreviation.
Okay, no worries. I think this gentleman has a question.
Now. Yeah. So that question about the API modules was a thing which immediately struck me, because I was involved in the development of the internet that we use, and it's still using, and people build things for the internet. And the basics around that were having some very clever architects at the center. We used to call them the white robes. In our computer engineering society, there were white robes, grey robes, and black robes. And black robes, we worked on the delivery of actual products and things. White robes looked at the architecture, and they were the people who were on the standards bodies. So they defined the standards for APIs and the like. And when you think about the internet structure, you've got these different levels, socket levels. It was a good structure, and it's been robust. And it was designed for the future. And in a way, I think what you need is the internet for healthcare, that you need to have some really top-level thinking about what are the standards that you'll need. And you're not talking about designing those modules, you're setting the standard for API that the suppliers have to conform with.
It's a little bit like at the very beginning of the day, when Mark was talking about the audio and the digital and analog equipment, there's a reason why all of that stuff can be plugged together, and it's because it is all a standard. An XLR cable will plug into another XLR cable, and all of them are interoperable by design from the very start. And as you say, they're all modular little pieces that you can build together into an AV room out of all these little bits that work together. Whereas we buy an EPR as an entire unit, which is not modular.
No, and the thing is, the architecture needs... so one of the reasons why the internet has survived so long, we had a little blip with the Millennium Bug, you might remember, because that wasn't an internet problem, that was some computer operating systems that were designed back in the 70s, hadn't got the right size capability to expand the data fields. When they were doing the internet development, they were looking at what's the scalability of the data fields. My bit was about authentication and how you know that a particular device is a particular device. And that was based on a particular scale of public-private key encryption. We designed that to be really robust with the forward operability that you would be able to increase the size of that scale of that key as computing power increased. We're still using the one that we originally spec'd, but time will come when we have to move that one on a bit. But that's the way to do it. And once you have that set of standards, then people can build to it. And that architecture, then you can have all the flexibility that we've got all of these developers all around the world developing internet solutions. Once you have that level. So that's my thought.
Thank you. Thank you for sharing your thoughts. Did anyone else have any questions? Jeff? Okay. And then the lady behind you. Jeff?
Yeah, I was listening to Radio 4 at the lunchtime. They were talking about, how do we fix the NHS, and they had a guy there who was the chair or CEO of the NHS Confederation, and he made an interesting statement, which I want to throw out to the panelists and see if they agree or disagree. But he basically said the fundamental model, and he's talking about digitalization, the fundamental model is broken, and it's because we're running a demand-led and building demand-led systems instead of building engagement-based systems.
Who would like to have a stab at that?
I'll take it. I'm not entirely sure what he means by an engagement-based system, in that it sounds a bit too vague to be specific, if you sort of mean. We are doing it wrong, though. But I would say that, the allegory for that is more like, if you go into the kitchen in the morning and open the drawer and the handle comes off, and you can fix it yourself, then you'll be able to fix that. You've got in-house capability, and you fix the handle, it's now fixed. That has taken you 5 minutes and cost you very little. If you don't personally have the capability, but you know someone who can do it, it might take a day, and they might ask you for 20 quid or something. If you can't do that and you have to go to a professional, then it's going to cost even more. There's a call-out fee, and the costs are going up because of how you've wrapped this simple problem into something that has to be outsourced. And procurement is the epitome of that. We fail because we decide that we've got to buy an incredibly complicated, coupled system that's not modular and has no standards. And we can't possibly do it in-house, so we have to outsource it. You can imagine if you were in charge of the procurement for this handle now, okay, so you don't live in the house, you have no vested interest in this house, it's somebody else's money being spent on somebody else's stuff. So you come in and say, right, well, that's a handle, but it's in a kitchen, so we're going to need to get a kitchen consultant in. We're going to have to, we need to do some user research about this handle, because I'm not keen to just put the same handle back on. I mean, that would be a disservice to our users, so we need to do an entire 6 months of discovery on that. And then...
And I'm a left-handed user, so I would also like it to be left-handed compatible, but I only visit the house, maybe never, so just add that in.
So that, but that goes in the spec. And then we've spent 18 months specifying how this handle is going to be, and it goes out to procurement. And then we would get really left-field quotes for this quite simple, straightforward thing to be fixed. And I'm being silly, but that is what we're doing every single time we procure anything, because we make it into a far more complicated thing. Nadia, it must be nodding, because this is exactly what happened with your... Yeah, I mean, that solution could have been provided by your organization for $1,000 if they had internal capability, or let you use your own capability, but they'll do neither of those things. It's $40,000 via procurement. So, I mean, I would go further than the Manifesto thing. Just say we are doing it wrong, and it's procurement that is the evil here.
I would agree on that statement, in as much that one of the core problems that's been witnessed in other sectors that have been addressed, and they've figured out how to address it, and they've delivered it, and the NHS hasn't, is essentially that the procurement departments are insufficiently digitally competent. Because if they were sufficiently digitally competent, they wouldn't specify, or even allow to be specified, certain types of systems, and they would specify systems in such a way that they actually serve the NHS purpose rather than the purpose of their supply chain, who's dictating the format of how you're going to buy it and what you're going to do and how you're going to maintain it, which then the NHS has, I believe, 80,000 different digital service providers. When you look at it from that point of view, that's not a manageable thing at scale, unless you build to be manageable at scale. And we're not.
Can I just add to that what was said? And I think there's another problem, is that like the NHS is very poor at recognizing its own expertise. I was getting feedback from one of my colleagues, and he was saying, oh, he sits on this and he has like a lot of digital expertise. But every time there was like a health board-wide meeting, either they had to find a medic who had an interest in this, or they decided they had to go get an external consultant. And it's like, why? And then I think the other thing is quite bad, and I think it's always a conflict between getting local solutions, because it has many advantages, or like standardizing something in the whole country. Like my parents just can't believe, like in Poland you have one app for all of governmental services, including like the Polish equivalent of the NHS. You can have your digital driving license on the same app as you can have your own prescriptions, you know, and you can send your prescription to your spouse, so that doesn't even have to be you who picks it up. So yeah, I think, so to put it, we suck on either end of the spectrum.
Well, actually, interestingly, that is exactly the observation that I think the CEO of the NHS Confederation was effectively making. When you're building systems to service your own internal need, first, which is what's happening, because it's all about the cost and the efficiency of those expensive clinical staff, and thereby it's good for the patient, and yes, we'll make it nice for the patient once we've figured out what we want. You've actually forgotten that actually engagement is a two-person process, and I don't believe that we're building digital systems now that actually are about the engagement process of the patient equal to the needs and services of the business and the organisation, because of that cost imperative that sort of overwhelms everything, and eventually ends up with the kind of digital crap that we end up with that costs us a fortune.
Well, and they were spec'd and procured 30 years ago when the recognition that, you know, patient involvement is probably a good thing.
And they weren't looking far enough ahead.
I'm really sorry, guys. I'm going to have to cut this debate, and it's lunchtime. I think we can definitely. Is it not lunchtime? It's close. Okay, fine. No, this session is coming to a close. I'm going to have to encourage you guys to continue this debate, these discussions during lunchtime. But yeah, one final round of applause for our amazing panel.